voice is coming. 13 participants have joined. Shall we wait for another 2 minutes or shall we start? 8 o'clock, it's sharp 8 o'clock.
We'll wait Aruna for 2 minutes.
Okay, okay. Manish is there, huh? Manish has joined. Amrish, Manish, Anant, Dr. Amma is there, Dr. Suman is there, Dr. Shiva is there, Munita ma'am is there. Thank you. I'll just join Banita Paranga. Anant is there. Okay. And mute Pananga Raja.
Yes.
Pen Good evening, everybody. And again, welcome to the monthly Indepso webinar series. Today, we are going to discuss about gastric cancer with peritoneal metastasis as a panel discussion. And I am really honored to have such an esteemed panel, the very much sought out panel. First of all, starting with Dr. Munita ma'am. She is a senior pathologist at the Tata Memorial Center, Mumbai. Then we have two surgical oncologists, senior surgical oncologists, Dr. Manish Bhandare from Tata Memorial Center, Actrec, Navi Mumbai, and Dr. Amrish Chatterjee, who is a senior surgical oncologist from Apollo Hospitals, Pune. We have two senior medical oncologists with us, Dr. Shivkumar Kailasam from Dharan Cancer Specialty, Salem, and Dr. Anand Ramaswamy from Tata Memorial Center, Mumbai. Again, we have one senior radiologist, Dr. Suman Kumar from Fortis Mulund, and Dr. Amay Puranik he's a nuclear medicine physician from Tata Memorial Center, Mumbai. So we actually have a mix of from private practice, from Tata Memorial Center, as well as from the peripheries. So let us see and how interesting the discussion is going to be. So without further delay, we'll start with the case presentation. So this is a 53-year-old gentleman who has come to the OPD. Otherwise, he's ECOG1, diabetic hypertensive, well controlled. Presented with complaints of intermittent upper abdominal pain for 1 year. Evaluated outside with an upper GI endoscopy, which showed a large ulceroproliferative growth in the pre-pyloric region. But the D1 and D2 were normal. Biopsy was taken, which was reported as a poorly differentiated adenocarcinoma. We got the slides and blocks for review at our center, and it was reported as poorly differentiated adenocarcinoma with signet ring cell features. To begin the panel discussion, I would ask Dr. Munita ma'am, um, why do you think, what is the difficulty in identifying these signet ring cell cancers? And what special precaution needs to be taken while doing biopsies for these kind of malignancies?
So, Aruna, the problem with signet ring cell carcinomas is they are very easy to diagnose. On one hand, they may be the most easy because you can identify those classical signet ring cells, which are easy to identify. But on the other hand, they can be very difficult because they can be singly scattered and they can mimic. There are so many mimickers of signet ring cells. So this is a diagnosis that can sometimes be very challenging if, especially it is a post treatment scenario. Those conditions, you can have very scanty cells, and there can be a lot of fibrosis, and they can be mixed with other macrophages and other immune cells where they can be difficult to identify. So and also they can mimic other poorly differentiated malignant tumors like lymphomas. So sometimes we have to use immunohistochemistry to distinguish whether these are epithelial or whether they are lymphoma cells. So we need to distinguish from them. Mostly, there can be problem at the peritoneal sites or mental sites where the specimen may be where the tumor cells may be very sparse, and they can be mistaken for histiocytes, or may be very difficult to distinguish from the treatment response from the macrophages that come after treatment. So sometimes we have to resort to immunohistochemistry. So not on all cases, but they can be challenging.
Especially, what would you advise the medical gastroenterologist or the surgical oncologist while taking biopsies if there is an abnormal thickening and there is no obvious disease? Is there something like what I read was that signet ring cell cancers, they tend to grow subepithelially, so deep biopsies is
Deeper biopsies are required, and more mapping biopsies are also required. So we need more deeper tissue so that we do not miss these. So these can be singly scattered, so there can be issue with the sampling. So we have to make sure that we provide adequate number of biopsy specimens, especially deeper biopsies.
And do these cancers have higher chances of skip metastasis as compared to the routine histological subtypes?
Yes, compared to the tubular or the more conventional ones, these tend to be more poorly cohesive. They come under the category of poorly cohesive cells. They are much more, they spread much more, and they are the ones which are associated with more peritoneal dissemination and more lymphatic emboli, and they are biologically aggressive. And their intercellular connections are much lost, and they tend to have more spread. They widely spread, so they are much more biologically aggressive.
Yes, ma'am. Yes, ma'am. So this classification is known to most of us, the intestinal type, diffuse type, and the very well known WHO classification, the tubular adenocarcinoma, papillary mucinous, as well as the signet ring cell. Madam, I wanted to have your comment on the rare subtypes, the hepatoid adenocarcinomas or carcinomas with lymphoid stroma. Do they have any clinical relevance? Though they are rare, if you see a report, what do we
So,
expect?
so majority of the times we get either the conventional tubular adenocarcinomas or the intestinal type, and then you have the other types are the diffuse type or the signet ring cell type, the poorly cohesive category, which so these are the vast majority of the tumors. Then we can also get papillary and mucinous types. And much rarer are these subtypes that we should be aware of. One is the hepatoid adenocarcinoma, which is a carcinoma which shows the hepatocytic differentiation and can produce AFP. So these are the cancers which are much more aggressive, have more peritoneal, liver, and ovarian metastasis. So they are much aggressive, and they may also be poorly recognized. They may be under recognized by the pathologist also. So they may, in one spectrum, they can look like very just poorly differentiated adenocarcinomas. On the other hand, in a classical scenario, they would look like HCC or hepatocellular carcinoma, and they can have a range of differentiation. And intermediate, you can have an enteroblastic type of adenocarcinoma. So recognition and awareness among both pathologists and clinicians is required, and these are much more aggressive and frequently associated with serum AFP levels.
Yeah.
And another
No,
Yes.
no. Please continue.
And a small some of these subtypes are also associated with more HER2 expression and rarely NTRK expression, which can lead to, which can be targeted. And the other is the carcinoma with lymphoid stroma. These are the ones which are EBV positive, and they have they are morphologically they can be recognized by having a lymphoid rich stroma, and they can be confirmed with performing EBER-ish, EBV. They show EBV positivity, and they're frequently associated with PDL1 overexpression, and they are otherwise less aggressive and much more indolent compared to other conventional adenocarcinomas.
And the diagnosis, ma'am, is mostly through IHCs or
Yes, diagnosis, it can be suspected on routine HNE slides, and they can be confirmed on hepatoid can be confirmed by doing markers for hepatocytic differentiations, glypican-3 and arginase and HepPAR. And carcinoma with lymphoid stroma shows EBER-ish in situ hybridization. So if it can be picked up by the pathologist, then it can be this test can be done EBER-ish.
Right, ma'am. So, moving on to imaging, I would like to ask the medical oncologist as well as a surgical oncologist. Such a patient, when comes to you, Dr. Ambrish, Dr. Manish, or Dr. Shiv Kumar, Dr. Anand, anybody can take this question. What would be your preferred imaging modality? Whether it will be a CECT thorax, abdomen, pelvis, or an FDG, or a FAPI, or an MRI with CCD thorax. Yeah, Manish has joined us. So, what would be your preferred modality, Dr. Manish?
The preferred modality is CECT TAP. That is what
Yes,
we follow. Of course, the others are options. We know that FAPI PET is gaining more and more interest
yes,
in gastric as well as some of the HPV tumors. But CT TAP is something that we would follow simply because we anyway have to do an peritoneal staging by a staging laparoscopy. I don't think we can replace that with any of the imaging at
absolutely,
present. And
absolutely, yes.
that is where CT TAP is what becomes economical, easily possible, and we stick to that one modality.
So, would you straight away go ahead with PET CT, or you will do a CCT and then decide on that?
In general, we know there has been reports about FDG not being so effective in
Yes,
gastric,
yes,
especially
yes,
signatoring.
yes.
So all those things also are there. Considering that, we would rarely do a FDG scan.
Right,
We would do a
right.
CT TAP. And
CT tab.
occasionally we have done, yes, FAPI PETs also as a part of workup sometimes, but that is more of a evaluation and in a clinical study setting rather than doing it as a
As a
routine.
routine. Yeah, perfect, perfect. So, coming to Dr. Suman, can you just, for the benefit of the audience, see the CT scan and let us know what is the extent of peritoneal disease? And this one has actually a lot of disease, but whether can you tell us about what the surgeon will ask you more commonly, what is inoperable disease, and in limited PCI, what is the areas which can be easily missed?
Yeah, the CT scan of abdomen and pelvis shows soft tissue thickening seen involving the peritoneum and in the omentum, and there is a scalloping of the liver uh, in the subdiaphragmatic region, and also there is involvement of the periportal region, and there is involvement of the uh, disease in the lesser sac also. So I would think the gross disease even the surgeon can pick up. What
Yes,
they want to know is whether there is disease. What is the PCI? Is it below 20 or more than 20? Is the periportal region porta is involved or not? Is the lesser sac involved or not? And is the mesentery involved or not?
root of
So is it amenable for cytoreductive surgery or not? That's the first thing. So if it is extensive disease and on imaging, if there is a extensive mesenteric disease, then it's outright, there is no need of any laparoscopy also. On imaging only, the patient will be palliative.
yes,
But
yes.
if there is a the patient is in borderline where the PCI is amenable for cytoreductive surgery, then the imaging plays a vital role. The mesenteric disease is one of the gray areas where CT might underscore, they underestimate the actual amount of disease. So
Yes.
any nodule which is less than 0.5 centimeters is difficult to be picked up on CT scan.
Yes.
And the indirect signs of mesenteric involvement is there is a cocooning of the small bowel loops, there is thickening of the small bowel mesentery, and fat standing along the superior mesenteric artery. These are the things which will indicate us, which will point us towards the mesenteric disease, mesenteric involvement.
Right.
And in case of a gastric cancer, then any extensive peritoneal disease burden would be contraindication for a surgery.
Yes, absolutely. Yes, yes.
Yeah.
So, in limited peritoneal disease per se, are there
Yeah.
any specific areas which should not be missed? Any comments on that?
Yeah, the porta is what the surgeons predominantly ask, whether can it is clear the disease in the porta, and
Yes.
is the mesentery involved or not? Is the root of mesentery involved or not? And if there is a disease in the lesser sac, and if the extent of surgery is going to be extensive, where they might have to do a Whipple's, then again it's a contraindication. So
Yes.
the subdiaphragmatic regions and the pelvic peritoneum, that's the one area where the CT can miss, because
Mhm.
pelvis is not CT is not the modality for imaging the pelvis properly. So in case where the tumor markers point towards a peritoneal disease burden, and then the CT, there is no peritoneal nodule, obvious peritoneal nodule, then MRI would be helpful.
Yes.
So MRI definitely is better. And in Tata, I think there is a study going on where the early gastric cancers are screened for peritoneal disease with MRI, and then the patient is taken for laparoscopy to see if the MRI correlates well with the laparoscopic findings.
Right, right, right. But the point to be given to the audience is that CT is the usually CT will pick up these areas which signs of inoperability as well as if there is heavy peritoneal disease. But when
Yes,
subtle disease needs to be identified, MRI is preferred, right?
correct.
So
MRI, the only disadvantage of the MRI is the long time and the availability of the modality everywhere. So CT is
yes,
the main modality for imaging. And in case of early disease, or if there is any clarification required, I think the MRI would be helpful in problem solving cases.
right, right. So this is one example where there was a small nodule on the falciform, which
Yeah.
was not seen on CT and not even on the CNDR, the portal phase and the delayed images on MRI, but it was picked up on a diffusion weighted MRI. So MRI can maybe I think as a follow up when you're suspecting recurrence, it may be more helpful and obviously in early or limited peritoneal disease.
Yes, yes.
Yes. Yes, so so that is one reason, and it can be used as a problem-solving tool where the findings are not equivocal. But as Dr. Manish said, diagnostic laparoscopy remains the gold standard where you can confirm the extent of peritoneal disease as well as can obtain cytology for ascites or washings if no ascites. So moving on to the next modality of imaging, Dr. Amay, would you like to elaborate the difference between an FDG as well as a FAPI PET?
Yeah, am I audible?
Yeah, this one is of these slides have been given by Dr. Amay, and this is a distal stomach showing an abnormal thickening. Yeah, you're audible. You're very much audible.
Yeah, so basically FDG PET is what looks at the glucose transporters, uh, and PAPI is what looks at the stroma, basically the fibroblast activation proteins which are present in the cancer-associated fibroblast. So they look at altogether two different uh, targets. One is
Yes,
which is cellular in the cancer cell, and another is in the tumor microenvironment. So
yes,
typically, FDG PET is never done for a gastric cancer in at any level. Uh, but with the advent of FAPI, we have been doing FAPI PET with CECT. I mean, PET with CECT routinely now in patients with gastric cancer. Uh, Regarding if I have to quote any evidence, the evidence is only retrospective. There is no prospective data. But for peritoneal disease, we have just completed our study on locally advanced gallbladder cancers,
Mhm.
and we have picked up. There was almost in 13% patients, so among them, 6 patients showed peritoneal disease in which staging laparoscopy was negative. I mean, on FAPI.
Staging laparoscopy was negative.
Yeah.
Then how was the disease confirmed?
So out of which, in 3 patients, it was confirmed on cytology,
Okay.
and remaining 3 patients, there was obvious disease in the form of a nodule. So basically, it was also seen on CT, but it was just subtle pickup by PAPI, and then retrospectively on hindsight, CT also picked up the disease. So
Okay.
that is what we have. That is what our experience is in peritoneal disease for FAPI.
Maybe those were the areas which were not accessible to laparoscopy because it is less
Possibly.
likely, yeah, that it will be missed on
Of course, this is
laparoscopy.
just a exploratory study, and it doesn't mean that staging lab should be replaced. But then
Right.
FAPI definitely has the potential, to pick up peritoneal disease
Yes.
much better than conventional imaging.
So because we had a recent case, it was a colorectal cancer. The
Yeah.
MRI was also done, the FAPI was also done, but the extent of peritoneal disease was far too much because the score radiological PCA was around 6 out
Mm.
of 39, and in 10 out of 39.
Mm.
But there was too much of disease in when we went in, and it was a
Right.
previously operated case, so a lot of adhesions. So once we release the additions, maybe additions reduce the pickup rate. We will have to look into it,
Right.
right? Yeah, yeah. So this is again another case of a proximal stomach. So even the nodes from metastatic CA stomach will not have an FDG uptake, is it?
Yeah. I mean, overall, I would say FDG. You can get FDG uptake, but we are never having that diagnostic confidence on FDG. But I mean, CECT, I would say it is ultimately the CT component on FDG PET which helps
Right.
us in diagnosing the lesions more than the FDG uptake.
Yes, yes. Yes. So exactly what Dr. Amay said, especially in signet-ring cell and mucinous adenocarcinomas, where there is low tissue density and heavy mucin pooling, which do not consume glucose. That is the reason why they become invisible or faint on FDG. And again, the healthy intestines, which naturally absorb glucose, the high ambient background noise or glow, which makes the small bowel and mesenteric peritoneal metastasis not evident on an FDG. But and also fasting is not needed, as is needed in FDG PET. But concerning the cost and availability, these are the present constraints, right? Because it is available only in the metro cities. Probably soon, as more and more evidence comes, it will be available elsewhere as well. Right, Dr. Amir? Can
Yeah,
you?
right.
Yeah, yeah, yeah. So we did a PET CT for this case, and there was a disease in the distal stomach and perigastric nodes, and there was no ascites, there was no obvious peritoneal disease. And we proceeded with the next step, that is tumor markers. So this is for both the medical oncologist as well as the surgical oncologist. The tumor markers which we commonly do are CA and CA 19.9. What is your opinion on CA 125 and gastric cancer? Anand or Shivkumar or
I guess so. Hi, Aruna. Am I
hi.
audible?
Yes, yes, very much.
Okay. So I think, I mean, if you're suspecting some kind of ovarian disease or some cystic thing on the CT in a lady, then CA125 is as good or as bad a marker as CA or CA 19.9. I mean, your diagnostic and follow-up is essentially going to be clinical and radiological, and these are adjunct markers only. Of
Right.
course, if these go up and down, it gives you an idea, but you're primarily going to take decisions on the scans and physical complaints.
Yes, yes. No, but no, my question is because many of the oncologists refer to CA 125 as not to be done, especially for male patients, and only to be done in female patients. So I wanted to clear this
Oh,
fact. That is why this question. Manish, what do you say?
About tumor
CA120.
markers,
About doing
CA120
CA125 as a tumor marker in a male patient.
in particular, I would say very little evidence for doing it for gastric cancer anyway, whether it is male patient or a female patient.
Right.
Because it becomes very non-specific, and any peritoneal involvement, it can go up possibly.
Right. Exactly.
Uh,
So
but
because CA125 is actually routinely performed in Japan, where gastric cancer and peritoneal metastasis is very commonly treated, and it is a part of the tumor marker panel which is done there. And in cases with exactly as heavy peritoneal disease, the CA125 is elevated because it is also secreted by the mesothelial cells of the peritoneum, and it not as a diagnostic but as a follow-up, it is an
follow
important tumor
yes,
marker. So we
yes.
did in our center we do all three markers, but all of them were normal. And next, coming to the molecular testing, um, Munita ma'am, what do you suggest for such a patient with uh, locally advanced gastric cancer? What should be the molecular testing that will help us to proceed in the further treatment?
So there are various biomarkers that can be done, and that are routinely done for advanced cancers or for metastatic and unresectable tumors. And these can be performed on immunohistochemistry as a surrogate for their underlying mutational status. So one of the common ones that we do are HER2, that can be done by immunohistochemistry, and the HER2 scoring is different from what we do in breast carcinoma, and is what is prescribed for gastric cancer is slightly different. And based on the score, we can do, if it is scored from 0 to 3 plus, and if it is 3 plus, it goes. We can take it as a HER2 positive case. But if it is 2 plus, then we need to confirm it with FISH. Then the other markers that we can do is the MSI testing we can do, which again on IHC we can do the MMR proteins, the mismatch
Yes.
repair proteins, which tell us the mismatch, the MMR status, whether deficient or proficient. And then we can do PD-L1 testing. For that, we need to give a combined positive score, which looks at the positivity in the tumor cells as well as the immune cells, and gives it as a score with the highest cap at 100.
Yes.
And another one upcoming emerging marker is the Claudin 18 immunohistochemistry that can be done which is a companion diagnostic test that is also at least 75% of the tumor cells should show moderate to strong membranous positivity. So these biomarkers can be done to assess this, to look for so that they can inform targeted treatments.
Right, right. So again, NCCN, as Madam rightly mentioned, has given it as a guideline that these should be tested in patients with newly diagnosed gastric and gastroesophageal junction cancers. My question to Anand as well as Shivkumar and Manish and Amrish is: have you all started doing Claudin 18.2 routinely in gastric cancer patients with peritoneal metastasis or locally advanced gastric cancer?
No, Arun, I am not doing.
Not
No,
routine, not routine.
not routine. Anand?
Yeah, in resectable or operable gastric cancers, the biomarkers that do inform are probably CPS and MSI only. There is limited role for HER2 and Claudin. In advanced gastric cancers, all four are important, and we are doing Claudin as well at TMH. We've
Right.
published some data on it as well.
What is the percentage of positivity that you get?
Almost the same as the international data. I think ours was 32%.
Right.
And this
That's
was
quite a
using the role.
big number. Yeah.
Yes,
Yeah.
yes, it was.
Yes. Yes. So again, we are also not doing here. So this patient, we did HER2, PDL1 as well as MSI. So HER2 was negative, PDL1 was 0%, as well as it was MMR proficient. So then we proceeded with the next step, that was a staging laparoscopy. So as you can see, the upper half of the stomach looks clean. There is no serosal disease as well. So for us, the diagnosis till now was locally advanced distal gastric cancer. And this is, as you can see, there is a bulky disease in the antropyloric region. And then we had this surprise. There were two areas of peritoneal disease. So that is the area 2 having a score of 1. Then we inspected the lesser omentum area, looked clean. The diaphragmatic peritoneae were clean. The omentum, the small bowel mesentery was fine. There was no ascites, and we did take peritoneal washings for cytology. I don't have the video, but there was one deposit in the pelvic peritoneum. Some technical glitch, and that part was not recorded. So coming to this area, so this is my question to both Dr. Manish and Dr. Amrish. So when you see this area on a staging laparoscopy, do you think it's a disease or it is a scar? Or if it is disease, what would be the score? What is your opinion?
I would think this on one image as a scar.
Yes.
But Amrish, what's your take? Amrish is there?
Let's ask Anant and Shivkumar what is their opinion, or
They
ma'am
may not
also.
be
Yeah, I know.
because
Just
they
as a
don't
guess.
routinely see this type of a picture because then it makes difficult. But I think I would think this as a scar,
Yes,
and I would
yes,
definitely do a biopsy and a frozen section or a histology evaluation of this
yes,
particular
yes.
area. The
So
other
this
one, which was close to the stomach, was typically classically a deposit.
peritoneal. Yes,
Yeah.
yes, yes. And for the benefit of the audience, this can be very well be a scar, but it is important to take biopsy and confirm and document it. Pictorial documentation is always better, and if you can record the videos, well and good. More or less, these flat areas, innocuous areas can as well be scar, but better to document before declaring them as a scar and no evidence of disease. The other thing is to document it as per the regions, as given by Professor Sugar Baker, and this is quite well known to the those managing peritoneal surface oncology. The abdomen is divided into 13 regions, and the lesions are score is given to every region. Lesion size score is given to every region, and then the total is the 39. So this patient had a score 1 in the area 2 and the score 2 in area 6, and the score was 3 out of 39. Surprisingly, the cytology, or rather not surprisingly, the cytology also came positive for malignancy. So coming to the next treatment plan, so now it was a T3N1 M1 and M1 disease with PCI of 3 out of 39 and cytology positive. So moving to the neoadjuvant treatment, Dr. Anant, what would you prefer? Neoadjuvant chemotherapy or adding immunotherapy? What would be your preferred treatment of choice in this case?
This patient was what was the age of the patient?
He was, I think, 59 or something.
Okay, I'm assuming he was a fit patient. I think try
Fit.
everything. Yeah, try everything. Start with chemo first, send the biomarkers as was discussed,
Yes,
and add whatever you can based on the results of those markers.
yes.
And if you have the option of IP chemo in a good setup with ability to monitor, add that as well. These are aggressive cancers. I think we should throw the kitchen sink at it.
Right, perfect. What about Dr. Shivkumar? What about the durvalumab evidence, which is actually not dependent on the CPA score, depending upon the matter on trial, though it did not include patients with peritoneal metastasis. What is your take on adding immunotherapy in the form of durvalumab in this patient?
In this subset?
Yeah, in this case, yes.
Yeah, definitely we can try actually but that was in the neoadjuvant setting where they
Absolutely.
included from stage 2 to stage 4A. They
Yes.
excluded patients with peritoneal mets.
Right.
So this patient has got obvious peritoneal mets. Maybe we can extrapolate to the Dragon 101 data that has got a better OS data than what your
Yes.
Durva has got to do.
Yes.
So Matron definitely had proven its worth in the neoadjuvant setting. So it probably is one of the largest and global phase 3 double-blinded trial, which had shown a perioperative immunotherapy with Durva, had shown a EFS benefit. If you ask EFS benefit is enough, I think these are the aggressive cancers. Maybe these patients are going to need immunotherapy in the due course when they recur. I think
Yes.
it's the right time that you should incorporate immunotherapy in the perioperative setting as well.
Right, right. Dr. Manish, Dr. Amrish, your take on starting intraperitoneal treatment, bidirectional treatment upfront in this case, in such cases? Dr. Manish has been doing port-based treatment. So what is your opinion and what is your experience?
We have done few cases, but majority in the adjuvant setting and not as a neoadjuvant approach per se.
Right.
I think we should not directly. It is exciting the data from the Dragon One, which was mentioned just now, and both our medical oncologist colleagues have been more supportive for IP, but
Yes.
I would have a little reserved opinion about this because although we have seen an encouragement in the randomized setting, but we have to look at two things that one was the regime used was totally different. It was paclitaxel with S1 as a part of neoadjuvant therapy. We often practice FLOT and immunotherapy also added to that. So how does these things work out with toxicity? We don't know.
Yes, yes,
That is very important, I think. And the second part of it is that this is only Chinese study, limited to only China, or the again Asian population, particularly only from China. So again, that data also we have to really see that if whether it is replicated elsewhere also.
yes,
And then, of course, we can, of course, incorporate that. What the trial has shown that at least the intraperitoneal therapy is effective. That we
yes,
know. Whether
yes,
we should add that to our existing way of treating gastric cancer, which is probably more aggressive in terms of an IV therapy, we will have to prove that and then start using it, is what I would say.
yeah. So my say on this is that we may not be able to combine it with NACT and immunotherapy, but follow the protocol that was followed in Dragon or the other protocols with docetaxel cisplatin. We need to generate our own data before we can, really follow it or throw it saying that okay, it's not working in our set of patients. Um, Regarding PIPAC, what is your say in PIPAC, Amrish? I think Amrish is not
Not in
in,
the
yeah,
not in the neoadjuvant setting.
not in the neoadjuvant setting. Right. Manish, any role of PIPAC?
Yeah, similarly, I would say not in neoadjuvant because when the PCI is high, then PIPEC is usually used.
Even
So
upfront, would you prefer, especially when high PCI?
upfront,
Uh,
when high PCI is unlikely going to be a curative scenario.
Palliative
as a
patient.
palliative, as a palliative. I'm
As a
asking as a
palliative,
palliative.
yes, as a palliative, this can be a potentially good option, especially for interactable ascites or
Yes,
large
yes,
volume ascites. That definitely can work. But for a downstaging and for a potentially curative treatment,
yes. We still need
uh,
answer.
we
Yeah.
need answer. Yes.
Yes. So, for the benefit of the audience, PIPEC can be considered, especially when the patient may not be fit to undergo the present neoadjuvant treatment. PIPEC can be considered without intermittent IV chemotherapy, and maybe if the patient improves, uh, can consider for bidirectional with PIPEC. So that may be an option, but presently it is all palliative. So, just to recapitulate, systemic chemotherapy backbone is FOLFOX, CAPOX, or FLOT. FLOT is the one which is more preferred, but less responding in peritoneal disease as compared to the visceral metastasis. We have the TOGA trial for trastuzumab in HER2 positive patients. Then we have the checkmate and keynote for pembrolizumab as well as nivolumab. But again, these trials had a less number of patients with peritoneal metastasis. Coming to zolbetuximab, Anant, you have been doing Claudin 18.2 and you're saying the positivity is around 30 to 35%. So have you been able to treat these patients with the drug? Is this drug available in the country and what is the cost? What is the logistics?
So I have patients on second opinions who are come to me and they're on zolbetuximab. I've not treated any of these patients in TMH myself.
Right.
It's the next big target. There are going to be many drugs in this scenario. It's going to be available from next month in India. It's going to be expensive.
Yes.
I think in the range of 3 to 4 lakhs a month. So, it's going to be out of reach of a majority of patients, but in those patients who can afford it, it's a very good option because the difference in survival is around 4 to 6 months compared to chemo alone.
Right.
So, and in a advanced setting, 4 to 6 months is a lot. So,
Hmm.
yeah, you can use it in those who are affordable with, and the other problem is the testing is not yet available in many parts of the country. It's not been standardized. So
Yes.
only standardized labs which give you that report you should consider.
And you give it as a sole treatment, not in combination with chemotherapy,
No, no, no,
right?
no, no. It is
Yeah.
in combination. It's Folfox plus
Yeah.
Acha.
Capox.
zolbetuximab or Capox plus zolbetuximab.
Right.
And there are various regimens that are coming around, reduce the dose and all that. But for now, it is given with chemo.
Right. So, just to understand IP port-based treatment, so we have two drugs which are most commonly used, the docetaxel, paclitaxel, several phase 2 studies, especially from Asian countries, with median overall survival ranging from 12 to 43 months. And those with conversion surgery, in these cases, conversion surgery is possible at around 50 to 80%. This was the famous Phoenix gastric cancer trial, though did not reach its did not reach its primary endpoint on sensitivity analysis, which adjusted for the baseline ascites. It did show hazard ratio of 0.72, which was statistically significant. And this is the famous Dragon 1 trial, which Dr. Shiv Kumar mentioned. So this I wanted to specifically mention that those cases where conversion surgery was possible, the mean PCI in the systemic chemotherapy was around 14, and in the intraperitoneal and systemic was around 15. And these patients, when they were able to undergo a complete cytoreduction, they come to conversion surgery, were the ones who did the best with a median overall survival of 33.1 months as compared to 18.8 months who could not undergo surgery. Coming to PIPAC, the as we said that presently it is having only a role in palliation. Uh, the PIPAC Vervan trial is presently recruiting patients who are having cytology positive, minimal peritoneal disease less than or equal to 7 PCI to PIPAC versus systemic chemotherapy, and maybe as the results come, we will know where exactly PIPAC stands in the neoadjuvant setting. So our patient had a multidisciplinary tumor board discussion, and he was planned for NACT. He was anyways HER2 negative, PDL1 negative, as well as MMR proficient. They felt FLOT was not good, so he was treated. Our medical oncologist, so he was treated with 5 cycles of Capox, and as can be seen in the scan, there was a fairly good response. There is a decrease in size and metabolic activity in the stomach region, as well as complete metabolic resolution of the perigastric lymph nodes. So now the most talked about Periscope 2 trial. So is there any role of CRS and HIPEC in this case? Manish and Amrish, first I would like to know your opinion.
Amrish can comment first.
Amrish?
Can I get back in some time? Just please go ahead.
Okay. So, two of the important trials, I think, as Aruna mentioned, in 2026, Periscope 2 and Dragon 1. Dragon 1 is encouraging, of course, showed a response in a neoadjuvant setting when the HIPEC is used, but in repeated events. Now, Periscope is a HIPEC related study, and it has been a negative study for HIPEC because there is no survival advantage offered, and the toxicity shown was higher
Yes.
in Periscope in the patients who underwent surgery. And that's where the conclusion is in the line that when there is no benefit to survival and added toxicity, obviously we should not be using it as a part of it. But I would not say that this is a definite no for surgery for gastric cancer with peritoneal metastasis. I think
Absolutely.
what the trial says is that not all patients with low PCI should be subjected to a CRS HIPEC. This is what
Right.
should be the message. We need to
Right.
have more stringent selection criteria, more
Yes.
durable response to neoadjuvant therapy,
Right.
most at present systemic neoadjuvant only, but there is a possibility of combining an IP therapy also in
Right.
a trial scenario. And then depending on the response, depending on the marker positivity, depending on age, signaturing, histology versus not, all those things should be taken into account before planning a CRS HIPEC. So we have to have more stringent selection for offering CRS HIPEC is what this trial should be taken as.
Right, right. Absolutely. I agree with you, Manish. So, just to understand, so there are well-conducted systematic reviews and meta-analysis before the Periscope 2, which showed that CRS and HIPEC is safe and does improve survival in well-selected patients. We also have the 2022 SOGI-RENAPE consensus, which said that HIPEC should be offered in patients, in well-selected patients, and the preferred regimen is cisplatin and mitomycin C. Also, the NCCN has included patients who have responded to systemic chemotherapy or at least have a stable disease and a low PCI can be considered for cytoreductive surgery and maybe some form of intraperitoneal chemotherapy and or HIPEC. So these two are the randomized trials. One was in 2011, CRS with HIPEC versus CRS, the Yang et al., which showed overall survival significant improvement with the CRS HIPEC group. And then we have the Gastripec 2 trial, the Gastripec trial, which was the German trial, multi-center German trial, which did not show any overall survival between CRS versus CRS plus HIPEC, but it did show a statistically significant improvement in progression-free survival as well as metastasis-free survival. And then we have this Dragon trial. Now, I have quite a few points which I thought were, when we dive deep into when the Periscope 2 study, more than half of the patients had PN3 disease. So whether we could have really offered these cases CRS HIPEC is a question. Again, as Manish rightly said, that response to systemic therapy is very important, and only more than half I think almost 45 to 50% of the patients had a TRG of 4 to 5. So definitely the selection of patients for the surgical group should have been more stringent. CRS was offered within 12 weeks of the last cycle. So this is pretty long gap between surgery, between the neoadjuvant treatment as well as between the neoadjuvant treatment and CRS. We usually prefer to operate by 4 to 6 weeks, maximum 8 weeks. Also, the HIPEC that was used was oxaliplatin and docetaxel, the 460 milligram per meter square for 30 minutes. And we know that we are really doubtful whether the oxaliplatin-based HIPEC works after the results of PRODUCT 7 trial. The R1 resection rates were 24%. Again, we know that patients who undergo a complete cytoreduction do best. Again, 14% of the patients in the systemic chemotherapy group underwent CRS HIPEC outside the study protocol. This one thing I felt was really important, that though the median overall survival and the intention to treat analysis was not favoring the CRS HIPEC group, the per protocol analysis did show a survival difference of of a few months, though not statistically significant. So if I think these stringent criteria would have been followed, CRS HIPEC would have shown benefit. So this is my take. What is your opinion, Manish? I mean, you rightly said it, that more stringent selection,
I
more
absolutely.
response, more sustained response to systemic chemotherapy is important.
Absolutely, and I think you have enumerated all the details perfectly well in terms of the limitations. I think just in general, not talking about Periscope per se, but I feel every one of us focus on reading the conclusions of the study, but it's very important to see the limitations also to
Yes.
understand, especially when the studies are negative. A completely positive study is a different issue, but when there is a negative study, we must always, or a non-inferior study for that matter, we must look at the limitations, and then there will be, of course, specific indications for a particular treatment which is evaluated in that study.
Right, right. Amrish? No, it's Amrish's
Yeah,
mother's
yeah.
birth. Acha, okay. Can we have your opinion? Would you offer CRS hypothermia
Very
in your
very suitable.
practice?
If the PCI and the response is highly suitable for the patient, baseline PCI also, or especially for signet histologies, we should be more careful because that's a very, as it is already a known biological aggressive tumor. And also, other thing is the nodal status has to be taken into consideration, just not the peritoneal disease. If the patient has bulky retroperitoneal nodes, then
Yes.
even if it's less PCI, then it's not a candidate for CRS plus minus or high tech.
Yes.
So,
Yes.
as you and Dr. Manish both have that a very stringent protocol has to be set in. Each institution, each unit can develop their own based on the available evidences, but more or less it has to be feel that tumor biological behavior, the PCI, and the response to neoadjuvant chemotherapy, and the patient general condition. All four things.
Yes, absolutely, absolutely. So we did have a tumor board discussion, and after explaining all the pros and cons of the available data, the patient agreed, and we did a CRS and HIPEC. We did a subtotal gastrectomy, D2 lymphadenectomy, selective peritonectomy, as well as cisplatin. And so, quick question because we are nearing 9. So, what is the PCI cutoff? Manish, Amrish, and Anand Shivkumar, what is the PCI cutoff that you would refer the patient for CRS HIPEC?
6 or 7. That's
6 or 7. The NCCN says 10. Professor Olivier feels PCI 12 for non-signet and 6 to 7 for signet ring. So we do have
A
varied.
lot of
What do
these
we follow in
numbers
TMH?
a lot of these numbers are only philosophy, Aruna.
Yeah.
I mean, it depends on what your surgeon's comfortable with. Anywhere
Yes.
between 5 to 10, I think every institution can find its own good space.
Good number.
Beyond 10, I think most of us would be uncomfortable, and probably the surgeons would have a better idea of that.
Yes, yes. Manish, what do you follow? What cutoff do you follow in TMH?
So when we started that time also similarly what's discussed, we also were very encouraged with all these numbers which different centers practice. So we were also more interested. The highest PCI that I have done is I think 16 or 18 for a gastric cancer.
Right.
Young lady in our initial days thinking that this is going to be effective, curative.
Yeah.
But then once we have seen the data of all these patients, and then of course gradually we made our selection more and more strict and stringent. At least we shifted from 4 cycles to at least 8 cycles of chemotherapy as a neoadjuvant protocol.
Right.
We did not choose young patients. It's a little different because we always feel it's a young patient, we should give a benefit of doubt. But gastric cancer in young age, we know that the worst prognostic factor,
Absolutely.
even worse than having a signet ring in isolation, I would say. A gross nodal positivity is also a poor prognostic factor, should not be taken into account.
Yes, yes.
So when all these put together, even after that, when we saw the data, I think the best outcomes were when the PCI was less than 3.
3, okay.
Yeah,
Right. So
it is
we were
that.
right. This patient had a PCI 3 to begin with.
Absolutely. This is the perfect patient, I would say, into with whatever evidence data that we have today to offer CRS HIPEC. Anything above 6 becomes a problem in general, not only as a number cutoff, but in general, the other factors are also worse when the PCI index is high.
Yes, yes.
More related to that, I would say.
The next question, yeah. Amrish, you were saying something?
So,
Yes.
I remember this case which Dr. Manish mentioned, a young lady, and an aggressive surgery did not help. She landed up in obstruction. I think he's talking about the same lady, young girl. And It's not about, as we said, the PCI cutoff is more of to just the biological behavior of the disease. It's not that how much PCI we can operate or not operate. We can
Yes.
even operate PCI 39, but doesn't
Yes.
matter. Doesn't mean that we should operate. That's the take home. That a low cutoff is more of a for a stringent. Somebody may push it to 10 or 12, but how much is that is a
Really going to
it
benefit.
depends on that. Yeah, correct. Correct.
Yes, yes. The next question is the safety of subtotal gastrectomy. So this was one concern because majority of the cases of gastric cancer, though we don't see the numbers that you see in TMH, Dr. Manish, but the ones that we did were obviously for total gastrectomy. So when doing this case, I was really concerned that if I take the entire momentum, the short gastrics will go, though we preserved the posterior short gastric. So we did left gastric artery and vein preserving subtotal gastrectomy. We cleared the entire nodal disease along the lesser omentum as well as cleared the gastrohepatic ligament area. So what is your take on in this type of scenarios? Both Manish as well as Amrish.
So, standard subtotal gastrectomy would include the removal of the left gastric vessels also, but we
But
would of course have to preserve the short gastrics draining from the splenic hilum. And if the disease is entirely a distal based disease with a small peritoneal nodule in that region in the
right,
antrum, with the other one being in the pelvis, I think the greater momentum completely we can excise up to the short gastrics, beginning of the short gastrics, and then preserve that area. I think that should be perfectly okay in these kind of
right,
cases.
right. So my contention was that if we leave behind, because we know that if we leave behind greater momentum, especially patients with positive cytology, do have a high chance of recurrence in this splenic hilar region and the gastrosplenic ligament region. That is the reason why, as a routine, like we do for other cases, we have to do a total omentectomy. So that is where the doubt erupted, and so we did very meticulous removal of the lymph nodes as well as the fibrofatty tissue around the left gastric artery and vein for
Right.
achieving the safeguarding the vascularity of the stomach.
We can do that. Preserving the left gastric artery is not oncologically inferior by any means,
Right.
but it's just that the vascularity of the remaining stomach becomes robust in that case because that's
Yes.
the main supply. And
Yes.
when we
Yes.
divide the stomach with a
Yes.
stapling device, this is of course technical I'm talking about.
Right.
The because gastric vascularity is high, the intraluminal ooze or a bleed chance can be more. So in case if we do preserve a left gastric, we would always underrun the stomach staple line also, so
Yeah.
that we avoid any kind of a
Post-operative.
post-operative
Yeah.
problem. But
Yeah.
preserving a left gastric is not oncologically inferior by any means if we get good
Right.
practice.
Yes. Yes. Point well taken. Any just quickly call. Yes.
Can I, in this particular case, I would, since although you have done done, I would recommend a total gastrectomy for two reasons. One is this is signet histology. We are talking about signet, they might have skip lesions also. Plus, when you're doing such an aggressive surgical procedure and you want to achieve a CC0, then a
Yes.
total gastrectomy is a safer procedure. It is not and it will definitely the skip lesions and the momentum and the peritoneum, everything is taken care of.
Right. Maybe I felt I like to differ saying because if you could preserve some part of a stomach at least and you're getting a good margin and no serosal disease, so I would next time also I think prefer a subtotal gastrectomy anytime when I can preserve the stomach because these patients do post-operatively as compared to subtotal gastrectomy they are little more morbidity as compared to a subtotal gastrectomy, the total gastrectomy patients. So,
So
yes,
agree with Aruna, I think, for
yes,
the reason that yes, maybe we feel that we are being trying to achieve more by doing more surgery, but that
yes,
doesn't always happen. And the weight loss
Yes.
significantly high when you do a total gastrectomy as against a
Yes.
subtotal.
Yes.
So again, when you get margins, you don't have to do it. The
Yes.
future chance of recurrence will always remain.
Right.
But for that to remove the entire stomach,
Yes.
not has not been proven also beneficial when we are not talking about peritoneal disease. The same discussion was for gastric cancer before, without a
Yes.
peritoneal disease.
Yes.
That
Yes.
remove the entire stomach so that there is no risk of future recurrence. But that
Yes.
was randomized trial and has not shown anything, which was a much earlier trial.
Right. So quickly, just yes or no, routine cholecystectomy as a part of CRS HIPEC?
No.
No. Amrish?
No.
Okay. No. Splenectomy? Obviously no. And as we already discussed, that the retroperitoneal lymph nodes, I would not be comfortable in taking those patients because the nodal disease is the one which will be playing an upper hand and giving rise to more of systemic disease. So moving on to the last thing, if HIPEC, what is your preferred regimen?
It's
Manish, Amrish?
cisplatin and mitomycin is what we have followed.
Right, right. Manish, sorry, Amrish, you follow the same?
Yeah, seems.
Right, right. So this was a histopathology report. There was fairly good tumor regression grade. Only the one negative thing, the nodes were also negative. The only one negative thing was the cytology continued to be positive. So I was happy that we had offered HIPEC for this patient. The last few things is, for example, if the adjuvant treatment, the patient has received all cycles of chemotherapy before surgery, and now there is residual disease. Anant Shivkumar, what would you do after seeing this patient in the OPD? What would you like to give this patient?
I
So
think we
the
should give some form of maintenance therapy. I don't call it as an adjuvant.
Right.
Some form of maintenance. I think she had received 5 cycles of Capox.
He had received. Yeah.
Sorry, sorry. So maybe I can take a leaf out of Resolve trial and leaf out of Capital trial.
Yes.
Maybe I can add 3 more cycles of Capox, and then
Yes.
I'll put the patient on S1 maintenance as well.
Right. Anand, you have any other opinion?
Yeah, for sure, complete 6 months of chemo, which would be 3 cycles of Capox.
Yes.
There is a study in advanced gastric cancers from India where we said that maintenance really does not help too much.
Yes.
So, but I understand the philosophy behind it because it's a stage 4 cancer,
Yes.
and that depends on the treating oncologist, I guess.
Yes. So we are actually, the plan is to complete 3 more cycles of Capox and followed by 2 years of S1. We are maintaining the data of this maintenance treatment and let's see what the result comes. The last question about the follow-up protocol. What is the imaging modality you would prefer, Dr. Suman, Dr. Amay, in during follow-up of these patients? What would you be comfortable if you are given the choice that okay, the patient has undergone this entire treatment and now has raising tumor markers, slight increase in tumor markers, what would be your imaging modality of choice?
Thorax abdo-pelvis, my recommendation would be, and if there is any doubt, in the sense like at least it can help us in detecting a lesion, and if it correlates well with the tumor markers, and if the surgeon is not sure that this lesion is a post-treatment change or a disease, then maybe a FAPI afterwards.
Right, right.
Yeah, if at all we are going to do a CECT, then I would rather go ahead with a FAPI CECT, like
Right.
CECT right away.
Right. Correct. So this is just a algorithm of what we have discussed, and the most important thing, Dr. Munita ma'am has been waiting very patiently throughout our surgical and medical oncology discussion. And as we all know, biology is the king. Madam, I want you to give us the final remark on managing patients of gastric cancer with peritoneal metastasis. You are the one who is most experienced. You have seen the treatment evolve. What would you like to give as the final comments?
So I would again reinforce what you have said, that biology is the king, and you have to take into cognizance what is the biology and customize your treatment according to that. And signet ring is an aggressive, biologically aggressive disease, and you have to respect the biology. And now we have a lot of biomarkers which can inform what are the treatments that can be useful.
Yes.
So respect biology.
Yes, absolutely, ma'am. Thank you so much. Just towards the end, I would take this opportunity to remind everyone who is attending that in the mid of September, we have this very interesting oncology group of Pune peritoneal surface as well as gynec oncology conference. Please do register, and then we all should be very proud that the next year, the SOGI International Congress on PSM is being conducted in our country. It is a matter of pride and prestige, and we should all make use of this opportunity to understand peritoneal surface malignancies, the nuances far better, and these the group registrations are available, which are at very subsidized rates. So most of us should make use of this opportunity. And lastly, the next panel discussion at the end of August would be on colorectal cancer with peritoneal metastasis, which will be headed by Dr. Jayaprakash and Dr. Niharika. So thank you so much for this excellent panel discussion, for being such wonderful experts. Any last comments? I think we are right a little overshooted the time, but yes, everybody must be waiting to, go on to their.
So
Aruna, very good session.
So just
conducted very well.
Thank you, Manish. Thanks to all of you,
I think we all
Dr. Amay,
enjoyed
Dr. Suman.
Yeah, good session, Aruna. I think you covered all the points. Thank you.
Thank you. Thank you. So special thanks to Munita ma'am, who has been there for the entire.
Thank you. I really enjoyed the whole session, conducted very well.
Ma'am, and
Thank
you
you.
are looking as younger as well. So hats off to you.
Thanks, Aruna. Good
thank
night.
you.
Thank you.
Thank you.
Thank you.
Thank you.
Thank
Thank
you.
you. Thank you so much.
Good night. Bye bye.
Bye.
Bye bye.